Hi everyone, welcome to another Wednesday VMR. Thank you so much for joining us. Oh my gosh, I see Jazz with the baby. Hello, friend. Hi. Oh my gosh, the youngest and the cutest member of the VMR. um, well, thank you so much for joining us. I'm super excited to be able to discuss today with the one and only Nicola. Thank you so much, Nicola, for making the time. And a big shout out to Magnus and Laura for doing scribing and teaching points. And we have an awesome case presenter from Brazil. Marcelo, do you want to say hi to everyone?
Hi everyone, my name is Marcelo. I'm a hospitalist here in Brazil and very excited to present this case for you today. Thank you very much.
Thank you so much for being here. Nicola, do you want to say hi? I know everybody knows you super well, but just for funsies.
Hello, all my very dear friends. Sharmin, the pleasure is all mine. I was looking forward to discussing with you. Thank you, Marcelo, for bringing the case. Thank you, Magnus and Lyra. And with that, yeah, that's all from my part.
Yeah, if you want to get the board up, then we can get started. All right, Marcella, we're ready for you.
I'm ready. Can I start? Okay. So the patient is a 22-year-old female who was admitted to the hospital complaining of fever, weight loss, and enlarged lymph nodes. So about the HPI, the patient reports that 8 months prior, she began experiencing daily afternoon fever, weight loss totaling 45 kilograms, and enlarged lymph nodes at both axillae and in the inguinal area bilaterally. She also reports shortness of breath on exertion, profound fatigue, diffuse arthralgias, and myalgia. On review of systems, the patient denies any ocular symptoms, dysphagia, abdominal pain, nausea, vomiting, diarrhea, and cough. And that's it for the first of the plot.
What an amazing start. I'll just share briefly my thoughts. This is somewhat overwhelming. There's so many moving parts to this, but I'll try to sort of ask the three questions that I always ask myself. So who is my patient? This is a 22-year-old female. This already sort of sets the stage. Then what's the tempo here? So we have actually more of a chronic picture. So we have 8 months of fever, weight loss. And then the last thing I always ask myself, is this a localized or a systemic process? And this is definitely a systemic process. So we have a young female patient with a chronic disease, which seems to be systemic. And then we can sort of try and anchor on some of these symptoms. There are a lot of them, but I can maybe touch upon the fever and maybe the weight loss lymphadenopathy. So this, to me, seems like it's a chronic consumptive disease. So I would sort of focus on my AIM mnemonic. So is this an autoimmune disease, which would fit? Is this an infectious disease, which would again fit? And is this malignancy? Now, malignancy could also potentially fit, but it's more rare, of course, in a younger patient. There are certain cancers that unfortunately do affect younger patients as well. Is this an autoimmune disease? Potentially, it would fit because of the age, it would fit because of the sex, and of course, it can always be an infection. Now, I think the lymphadenopathy is very intriguing. I think whenever I think of lymphadenopathy, it's important to see if I have lymphadenopathy maybe in one sort of region, it's more likely to be a localized process. So if I had lymphadenopathy only in the axilla with fever, I would be thinking about, is this a localized process? Is this potentially breast cancer? Is this an infection coming from the arm? But here we have lymphadenopathy bilaterally on both sides and in two regions. So we have the axilla, which are affected, and also the inguinal lymph nodes, which are also affected, which would then sort of prompt me to think about causes of generalized lymphadenopathy, which have sort of their own differential. And I think I'll go give the mic to Sharmin, who is surely going to help us out here.
Oh, Nicola, that was fantastic. I totally agree with you that a lot of moving parts. I'm like, right off the bat, I'm just struck by the age of the patient. It's like 22-year-old, quite young. In my experience, young folks don't like to present to care. And when they present, oftentimes, like by the virtue of being there and wanting to seek her, there's something going on. And I think like that weight loss, that 45 kilogram in 8 months, that is so significant. That makes me really worried for this patient. And then think about like the time course, oftentimes like I want this to be like a infectious etiology that is like easily treated, like something like mono or something like that. But again, like I think the time course argues against that, especially if we think like, the entire process, as you mentioned, like all of this is due to one underlying etiology. And like the lymphadenopathy itself, like makes us think, as you mentioned, for like systemic process that is quite inflammatory. And I think for now, I would like, as you mentioned, like lump the fevers, the night sweats, and intentional weight loss as like bucketed as like an inflammatory process until proven otherwise. I think the thing that I'm most worried about is like an underlying like autoimmune or like a malignant process. Yet I think it's also fair to think about infections, especially like your more indolent infection like mycobacterium, or like endemic mycosis. Those things at times can have like a more like indolent time course over months, and it can definitely be like inflammatory, causing weight loss and the night sweats. The other thing to always like think about is that like, it can this patient like can have like a chronic issue that then has superimposed by an infection. Again, like it can be more than one thing that is going on, but I think it's certainly given her age, like with malignancy, like leukemias and lymphomas, especially lymphomas, given um, her diffuse lymphadenopathy, it's something that it comes to my mind. There are like kind of like benign neoplasms, like Kikuchi or stuff like that. That again, like is a diagnosis of exclusion. Oftentimes, mostly like cervical, but they can have like diffuse manifestations as well as all of our friends in the autoimmune world. Um, the one thing to like always make sure when someone is like 22 and young is that like if there is oftentimes like they don't present to care that often before if there's anything like congenital or hereditary that is going on, like making sure like we have a good family history, and also like noting any other like prior infections or things would be really helpful. Yeah, I think like the generalized lymphadenopathy, the inflammatory generalized lymphadenopathy has me concerned, and I think the two buckets that I'm most worried about is autoimmune and neoplasms. However, I think like and then a more like indolent infections are also always worthy of considering. All right, Marcelo, I'm excited to hear more.
Okay, so in this second aliquot, I'm gonna give you the past medical history, the family history, and the social history. So for her past medical history, it's notable for one spontaneous abortion 2 years prior. She does not take any medication regularly. She has no history of surgeries, and she has no allergies. And her social history, she's a lifelong non-smoker. She does not drink alcohol, and she does not use illegal drugs. She's monogamous with her husband, and she lives in a rural area, and her occupation is housemaker. About family history, and both her parents are alive and they don't have any chronic illness, and she has a brother who is undergoing treatment for paracoccidioidomycosis, and an uncle who is undergoing treatment for pulmonary tuberculosis, but none of them live at the same house. And that's it for the second aliquot.
All right. I'll take a stab at it. Maybe Nicola, let me know if there is anything you add. Like, I think starting with the past medical history, like spontaneous abortions, miscarriages are quite common for women. So for one miscarriage, I think I'm just noting that, but oftentimes if you have like more recurrence of it, then you want to think about like if there is any systemic illnesses that could contributing, especially any like coagulopathies and all of those things. Um, and I think in terms of like the a family history and kind of like more it's notable that a lot of I think by the virtue of like where this patient might be living and where the rest of the family is living, that they are at risk of like infections like tuberculosis and paracocci. I think like TB is always a good thought, and especially with someone who's like coming in with like diffuse lymphadenopathies, fevers is like one of those indolent, like Mycobacterium is like one of those indolent ones that um, uh, that um, that I think is like worthy of like getting ruled out in anybody who presents especially young. Again, like we want this to be an infection that we can treat. That's my bias. And yeah, I do you have Nicola, what else are you thinking with this additional information?
Superb comments, Sharmin. Yeah, this is such an intriguing case. So I was sort of listening and anticipating for any potential source of infection. And another important thing, I was thinking about is this patient immunocompromised in any way, or is she immunocompetent? And I feel like this is a healthy young woman. But then we do kind of get this sort of signal that she has some family members with endemic infections. So I think infection is still on the table. But having immunocompetent patient in front of you does sort of help narrow down the differential, because as soon as you're immunocompromised, you open up a Pandora's box and you can basically get any infection, and that can be systematic. And then I was really listening and trying to sort of get a feel of any cancer history, any autoimmune history, but we then also get this bland family history. Unfortunately, you can always develop, de novo cancer or an autoimmune disease, but this is really intriguing. So we have some potential signal that this might be an endemic infection, which is now systemic, because it does seem that our patient is immunocompetent, doesn't have any risk factors, doesn't have any past medical history, doesn't take any medication, is monogamous. So this sort of does rule out a lot of potential entryways for a microbe. So yeah, I'm really interested in the physical exam for things like paracocci. I think if I remember correctly, you can see some changes in sort of the mouth, and the gingiva can be affected. Other than that, tuberculosis, potentially, lung auscultation, a chest X-ray could potentially also help us out here. And we didn't really touch upon, there was also, I think, some shortness of breath on exertion, which to me I always sort of interpret this as a problem with either the heart, the lung, or the hemoglobin. So is this a systemic infection which has its entry point or has affected the heart or the lung potentially? Could then explain also the shortness of breath. But I think this is such an intriguing case. There's so much that's still on the table, and I'm really looking forward to Marcelo's further information.
Okay, amazing. So in this third aliquot, I will share with you the physical exam. So the vitals show a heart rate of 112, blood pressure 100/60, respiratory rate 20, oxygen saturation is 96% on room air, and temperature of 39 degrees Celsius, which is equivalent to 102 Fahrenheit. On general inspection, the patient is in no acute distress and appears to be malnourished, with intense flaccidity of the breast and abdominal skin. The mucous membranes are pale, but there are no sclerorictures or jaundice. There are no abnormalities in the ocular and oropharyngeal exam. There are several painless, palpable lymph nodes at the right submandibular area, at the both axillae, and in the inguinal area bilaterally. On cardiac exam, the patient is tachycardic and the rhythm is regular, but there are no murmurs, friction rubs, or gallops. Lung auscultation is clear bilaterally. On abdominal exam, the liver is palpated 3 centimeters below the right costal margin at the right midclavicular line, and the spleen is palpated 5 centimeters below the left costal margin at the left midclavicular line, and there are no signs of ascites. Lower extremity exam reveals a symmetrical 1+ beating edema, and the right knee is mild swelling, but there's no associated erythema, warmth, or restriction in the region of motion. And the neuro exam is unremarkable. And there's no skin lesions also. That's it.
Wow, this is getting more interesting by the minute. There's so much to unpack here. Only one thing. Oh, I see it. So the temperature is at 39. So when I look at the vitals of this patient, I'm getting kind of worried. She has a fever. She has a blood pressure of 100/60 and a heart rate of 112. And presumably she has a sinus tachycardia, but actually sinus tachycardia is one of the most ominous ECG findings I can get. And if we were to calculate the shock index, she could potentially already, be in shock. What sort of shock could she have? I think potentially we might be dealing with a patient who is having septic shock. There might be something floating around in her blood, affecting both the lymph nodes, explaining both potentially the splenomegaly and the hepatomegaly as well. So where I would really be thinking about, does she have any entry point for a bacterial infection, which I don't think we saw any skin changes or anything like that. And if we don't have an entry point, it must still be a viral infection, which could also present in this way. So this is really intriguing. We have a patient who's really sick, malnourished. We have weight loss. It's a chronic ongoing process. And now she really is presenting in this very advanced stage. Then we have also the pale membranes, which I would interpret as potentially anemia. Now, there's so much going on. There's so many moving parts. I think I would have to consult Sharmin on this while I sort of gather my thoughts. Is this potentially a hemorrhagic fever? But I wouldn't know that Brazil is a dengue, Zika. I don't know if that's something that can occur in Brazil. But I think Sharmin surely has some more thoughts.
Yeah, very, very intriguing case, Nicola. I totally agree. And I feel like starting with the vital signs, I agree, like with the fever is like quite concerning that this is whatever is happening is ongoing. The blood pressure, blood pressure in one moment in time is like hard to judge what it means. Someone who's like 22-year-old, quite catectic, I think this is where I would expect her blood pressure. A lot of younger folks tend to have like lower blood pressures, But however, I think like your a gestalt of like, oh, I'm worried that this might be hypotension for this patient is very astute, and you want to make sure you treat it as like your NOMIS diagnosis, which is like, is this patient in sepsis, septic shock? So getting to your labs, getting lactate, and kind of like trending that blood pressure would be really, really helpful. And I wouldn't be surprised if this is like where this person might live. But again, like as we talked about, like whatever is going on, um, like whether this is like autoimmune and malignancy and infection can put you at a can cause like some level of immunosuppression that can cause further insults to the body. So like definitely getting that like whole infectious workup for like bacterial like pyogenic infections is very astute. I think like the diffuse lymphadenopathy. So we have like kind of confirmation of like someone who's coming in with the diffuse lymphadenopathy and hepatosplenomegaly, and sometimes like very, very easy ways, like spleen, you can think about it like a huge lymph node, right? So whatever it's causing, this pathology involves the spleen as well. And oftentimes like with the spleen is like, okay, what is causing it to be bigger? Is it like portal hypertension, is something of cirrhosis? Probably less likely. In this patient, we don't see any other evidence of like hyperestrogenemia, like no on her. And like as mentioned, no evidence of like a portal hypertension, like as like ascites on exam at least. However, it at least in the US is one of the most common cause of splenomegaly. And then the question becomes like, okay, are we having more like infiltrative diseases like granulomatous infections like TB, again, like I don't think this is like the time course doesn't go along with like a EBV. CMV, someone that might be immunocompromised is a good thought as well. Or like, you can have malignancy complications of it, as we talked about, like lymphomas being a big one too. And again, like some like as you mentioned, like other autoimmune diseases like sarcoid. So whatever the pathology is causing some degree of infiltration in this person. And then the other things to think about is like if she has any underlying hematological disorders that put her at risk of like kind of splenomegaly, like whether it's like infection with malaria or like some like genetic issues like thalassemias and stuff. Again, probably this like thalassemia, at least like you would have seen it by age 22. So again, like I think like for me, this is again is like a confirmation that we are dealing with like at least like an indolent, kind of like more infiltrative disease, like paracoxy, as you mentioned. Good, great memory with like the oral lesions. I do think like kind of like the more like a chronic lymphadenous spread of paracoxy can cause like diffuse lymphadenopathy as well. So I think like still our a big thing is like make sure there's no acute like pyogenic infections, as you mentioned, and then kind of like working care of for like these more like indolent infections. I think like the degree of systemic involvement with the basic labs would be really helpful to see like what other organs are involved. But I think again, like TB, disseminated fungal infections, and then malignancies are a big one. So it might become tissue becomes the issue unless like we get some more signals for other etiologies. I think your thought about like lung involvement, both paracoxy, TB, all of them can have lung involvement. So like getting your chest x-ray at least to start with is going to be really helpful. And sorry. Oh, yeah. And I think your thought that you initially shared on the last aliquot about like the immune status of this patient, very fair point. So like getting that HIV testing would be helpful as well to kind of like do we need to even like further broaden our very big differential? But I don't see anything yet that helps me narrow that differential for the diffuse lymphadenopathy. I think it's more confirmation that hopefully we're solving the right problem. Any other thoughts, Nicola?
That's so amazing. So I was able to gather my thoughts a bit, and I think the best way to make sort of progress here is definitely going to be looking at the labs, specifically looking at signs of inflammation, which I would sort of guess would be there, looking at ferritin, extremely high ferritin levels, potentially tipping us over to HLH, which is not a final diagnosis, which would have to be triggered either by a malignancy or an infection or an autoimmune process. Other than that, imaging, potentially again, imaging of the chest, looking at the lungs. We have this shortness of breath, which we still did not account for. And I would not be surprised if we see changes there. I think, yeah, it's still sort of anchoring to trying to find an anchor in this patient is still somewhat difficult because it's just so diffuse, so systemic, has a lot of things going on at the same time. I think lymphoma is still on the table, TBC is still on the table, endemic mycosis is still on the table, and these sort of spectrum of weird autoimmune diseases which tend to present with diffuse lymphadenopathy, like Still's disease, like sarcoidosis, like Castleman, like Kikuchi, are I think also still all on the table. So I'm really excited to look at the labs, look at some potential imaging, and I think once we have something to pin down, something to really really grabs our attention, I think we will be able to make more progress. HIV, testing for HIV, I think is also very, very important here.
Amazing discussion, guys. So in this fourth report, I'll give you labs and some images. So let's start with the labs. CBC shows a hemoglobin of 7.1 with an MCV of 79 and an MCH of 24. There's a leukocytosis of 20,000, and the differentiation shows no blasts, no bands, no atypical lymphocytes, and there's a neutrophilic predominancy. Platelets are 400,000. Electrolytes are normal. Creatinine is 0.4, BUN 10. Bicarb is 22. Lactate is normal, and the urinalysis is also normal. Total bilirubin is 1.2, and direct bilirubin is 0.7. AST 72, ALT 88, alk-phos 48, and GGT is 35. Albumin level is 2.4. The reticulocyte count is low, 0.6%. LDH is 360. Direct Coombs test is negative. Unfortunately, haptoglobin test wasn't available. Vitamin B12 is 454 and folate is 3.3. About the iron studies, serum iron is 18, transferrin saturation index is 9%, and TIBC is 200, and ferritin is above 2000, which was the upper limit of detectation in the kit used by the laboratory at that time. And CRP is 220, and ESR is 102. About the infectious workup, serologies for HIV, syphilis, leishmaniasis, hepatitis A, B, and C were all negative. We also performed serologies for Zika virus, dengue virus, chikungunya. They were all negative. And serologies for CMV, ABV, toxoplasmosis, and herpes virus are all negative too. And urinary antigen for histoplasmosis, blastomycosis, and paracoccidioidomycosis are negative. And the PPD is non-reactive. About the rheumatologic workup, ANA was positive at a titer of 1 to 40 with a final spectral nuclear pattern, but anti-double-strand DNA, anti-Smith, anti-SSA, and anti-SSB are all negative, and rheumatoid factor is also negative. About the images, EKG shows sinus tachycardia, but no other abnormalities. The right knee X-ray was unremarkable, and we performed CT scans of chest, abdomen, pelvis, and they showed lymphadenopathy at the submandibular area in both axilli, in inguinal area bilaterally, and in the mesenteric and perisplenic chains, along with hepatosplenomegaly and bilateral nephromegaly. And the lungs parenchyma were normal. And we performed also a bone marrow biopsy that revealed hypercellularity with marked increase in the megakaryocyte lineage. That's all. I think I said a lot. That's a lot to you to unpack.
Yeah. Oh my gosh, Marcelo, what a case. Okay, so we can like maybe take it one step at a time, and then Nicola, we can just go back and forth and delve deeper into all of this amazing information that was like provided to us. So. I think we can like maybe take it chunk by chunk, Nicola. So let's like start with kind of the hematology. Thank you so much for labeling that. It looks like that she has neutrophilic predominant leukocytosis, and oftentimes, like with neutrophilic predominant leukocytosis, we often think about like infection, any stress response can cause it, abscesses, all the good things. So again, I think is another marker of like inflammation in this person. The hemoglobin did catch my eyes because I was like debating whether she would be like pancytopenic or not, as we were like learning more through the exam on her. And sounds like the only she has a low hemoglobin with like a little bit of a higher platelets of like thrombocytosis, again another marker of inflammation. And with like a hemoglobin of 7.1, you always want to make sure there's no component of like acute blood loss going on, which we haven't really gotten any history of it. And she's definitely, with the amount of inflammation, at risk of like uh, anemia of like chronic disease. And then we get the the iron studies back, and I think that ferritin deserves a lot of attention and further thought. And Nicola, kudos to you for like bringing up HLH from the get-go and being worried about that. With like kind of elevated ferritin, there are a few infections that can cause like really elevated ferritins. And also, like, I think the one thing we always like concerned about is someone like coming in like kind of like diffuse lymphadenopathy would be like HLH. And the things to think about, like, is always like kind of like secondary etiology that again captures a lot of the infections that you would worry about, like in someone who is from Brazil, like visceral leishmaniasis can definitely do it. TB, fungal infections, paracoxy for sure can be one of the reasons of it. And the other ones are like hematologic, like lymphomas, leukemias, for sure, can do it as well. And then looking at the chemistry, we see that elevated LDH. Kudos on y'all for thinking about hemolysis. I think getting the smear, haptoglobin, a lot of the places are not available, which again, like, you just kind of go with a workup that you can do. And I think that elevated LDH makes me worried that, whatever makes me more worried about like an underlying malignancy that potentially is presenting with HLH, although like I would have expected like a bit more pancytopenia in this person. So maybe I'll just pause there for the CBC portion of it. Nicola, any additional thoughts?
I think you're spot on, Sharmin, and I don't think I can add a lot to it. So I think how I sort of interpreted the labs as sort of a first thought was profound inflammation. You have the white blood cell counts of 20, neutrophilic predominance. We have the ferritin of 2000. Now, a ferritin of 2000, I have a short approach to like ferritin in the thousands. And I think about HLH, I think about disseminated histoplasmosis, think about adult onset still disease and hemochromatosis. So I don't think it's hemochromatosis. I don't think adult onset still disease really fits the picture, but I think still a potentially systematic endemic infection like histo could potentially, still be on the table. Other than that, this could be HLH, and if it's HLH, which would we would I think have to convert it as diagnostic criteria, but I think the best sort of way to diagnose pretty much a lot of things is just to get a biopsy of it. If it's FLH, we need to find the cause of it, and I'm right there with you that unfortunately I feel like malignancy is somewhat likely here. Other than that, the CRP, I think again fits the inflammatory process. Um, and then kudos to Marcelo, you and your team, you tested for so many things. And I think in a patient like this, it's really is important to test for many things because many things I think can cause this sort of picture. So a lot of the things that we discussed, you checked for hepatitis, leishmaniasis, Zika, dengue, HIV, chikungunya. So a lot of the things we can sort of rule out. I mean, there's always tests and their sensitivity and specificity, but I think we can rely on those. The ANA is positive, but that's often the case, and especially in an acute infection when your plasma cells are producing immunoglobulins, like having a positive ANA is nothing really that concerning. Um, so yeah, and then we also got the imaging, which that didn't really show that much other than the lymphadenopathy. I would be really interested to see what's going on in the lymph nodes. So getting like a look, histopathological look in the lymph node. Is this potentially a lymphoma, which has been sitting in the background this whole time? Um, Causing potentially also HLH as a complication would be really interesting. What kind of lymphoma? I think Hodgkin's lymphoma would fit with the age. Um, but yeah, I'm trying to think what else I would get. Again, potentially getting more insights into sort of systemic endemic mycotic infections. I think histo, testing for histo potentially. There's sort of this serum antigens that you can then test for mycotic infections, but they are not that good as far as I understand. And then getting a look into the liver to see if there's if there's hemophagocytosis, and having a look into the lymph node. Are there any atypical cells there? Would also be quite interesting. As for the megakaryocytes, this could just be reactive. I mean, we have 400 platelets. This would fit well with inflammation. Um, I don't think this would be like a myeloproliferative neoplasm in this patient. So yeah, I think a biopsy would help us. What do you think, Sharmin?
Yeah, I think if we're thinking about this person, like a 22-year-old coming with like 8 months of um, inflammatory syndromes and lymphadenopathy with significant weight loss, found to have um, elevated markers from inflammation with like ferritin, leukocytosis, thrombocytosis, with kind of like again diffuse lymphadenopathy on exam, on imaging as well. I have a really hard time of like moving away from disseminated TB, just given where she is from and the risk factors there. So I think like TB has to be ruled out in her. Um, and I think like the the histo is a great thought. Sounds like the urine antigen was both histo and paracoxy was negative. Um, so I totally agree with you that like at the end, tissue is the issue, and a lymph node biopsy would be helpful. But I think like if I was the person treating her, I still think I would still want to make sure we're not dealing with like a disseminated infection like TB. And then I think the lymphomas, as you mentioned, getting that lymph node biopsy, like bone marrow, just showing like hypercellular doesn't really, doesn't. I still worry about a lymphoma in her. And then there's like like bunch of like autoimmune diseases that can do it, but I think road to more like kind of the autoimmune disease flavors, like still as you mentioned, is a really good thought. I don't know if like the demographic wise what I think it makes it a little less likely, but again I think road to those are just like making sure this is not TB, making sure this is not a lymphoma, and then seeing what shows up. All right, Marcella, back to you.
Amazing discussion, guys. So by that time, we called the surgical team, and they performed an inguinal lymph node excisional biopsy, and the histopathology suggested non-Hodgkin's lymphoma, but the immunochemistry revealed a reactive pattern. So we called them back, and they performed an axillary excisional, axillary lymph node excisional biopsy. And once again, the histopathology suggested non-Hodgkin's lymphoma, but the immunochemistry revealed a reactive pattern again. So by that time, the hemonc and the rheumatology teams were on board, and due to the extent of the lymphadenopathy, they suggested immunosuppressive dose of prednisone, which we did, and the patient improved a lot with resolution of fever, arthralgias, myalgias. However, upon tapering of the prednisone dose, the fever recurred, and that time there was a new feature, which was a maculopapular rash involving the limbs and chest, and this was a very faint rash, and it was present only during the fever episodes. So Mike, back to you guys.
Wow, this is gonna be a case I'm gonna remember for a very, very long time. This is so intriguing. And wow, I would, most of the time I think pathology really, nails down the diagnosis. It's really so almost a math sort of equation, you get a pathologist and he gives you the answer. But here we seem like we already excised 2 lymph nodes and we are still unsure is this malignancy, because I think it looks probably microscopically like a non-Hodgkin lymphoma, but then when they actually stain it, it looks to be more reactive. Now, what kind of non-Hodgkin's lymphoma are there? Which can occur? So, you have Burkitt's lymphoma, which can be sporadic, which can be endemic associated with EBV. I don't think Brazil is an endemic area for this. I sort of tend to think more about Africa with that. Then you can have sort of a primary mediastinal thymic large B-cell lymphoma. There's a lot of things that could be happening and going on here, but I think the rash is, I mean, on one hand, we have a good response to corticosteroids, which sort of lets me lean into the cells being reactive and is being maybe still an autoimmune process. And an autoimmune process with a maculopapular rash, is this going to turn out to be Still's disease? I feel like this would be such an atypical presentation of Still's disease. Lymphoma can get into the blood vessels and cause a rash, and this would be a very bad prognostic sign for the patient. So I hope it's not that. But yeah, Sharmin, what are your thoughts?
Yeah, so I agree with Nicola. I don't know, but I am loving the chance to nerd out about this case. Marcella, this is a fantastic case. So I think like the question is like, does all that is going on get explained by one disease, or does she have two things going on, right? Does she have an underlying lymphoma and a possible infection that, and the management of one triggers the other? Uh, I would have expected if the latter were true, if she had an overlying infection on top of like a lymphoma, then if when we would give steroids, the infection would flare up, right? It sounds like she gets steroids and then she gets better, and as it tapers, everything gets worse. So that kind of argues against an overlying infection. So it goes back to like, okay, is this all can be explained by a lymphoma? It is a bit an odd pattern for a lymphoma, and I can't explain the rash. It sounds like adult onset Still's disease almost, right? With the macular, I don't know if it's like a salmon colored rash of adult onset. Still's that kind of like get this pattern of like gets better with like steroids, however, it flares up again. That's what I worry about is like, are we dealing with like a kind of a more of an autoimmune flavor with the rash and with kind of the pattern of her symptoms? And the one thing that comes to mind is like adult onset Still disease, like the leukocytosis, elevated ferritin, the diffuse lymphadenopathy would be that. And kind of like the other things, like again like viral xanthoms, it can definitely cause that type of rash, but then again, like why does it show up when the steroids are off is a little bit weird to me. So yeah, so I'm not exactly sure, but that's where my mind is going. If I have to like put everything together, it would be more like an autoimmune, maybe like adult Still's disease. Nicola, any additional thoughts from you?
Sharmin, that's a great thought. Nothing really comes to mind. I mean, one thing I was entertaining the idea of dress syndrome, or we are liking the eosinophilia for that. I feel like the patient improves with corticosteroids, and this makes me lean towards an autoimmune process. But which one? Is this really Still's disease? I mean, we do also have the joint pain, the rash. I would have to, look up what is sort of the natural cause of Still's disease. What is the occurrence? Maybe the rash tends to occur later on. But this is such an intriguing case, and I know I'm going to do a lot of reading, and I know I'm going to remember a lot of the pearls that Lyra has already prepared for us. Um, so yeah, I think those are my final thoughts.
Yeah, Marcella, teach us what happened next.
Oh, fantastic discussion, guys. I'm amazed because at the time that I met the patient and about all the workup that we have done, I thought it was a very difficult case, but you both entertaining the right diagnosis. So after excluding infectious and neoplastic diseases and with the fulfillment of the Yamaguchi criteria, diagnosis of adult onset Still's disease was established. So the rheumatology team, they suggested to keep the prednisone dose and start her on methotrexate, which we did, and with complete resolution of fever and symptoms. So she was later discharged with a follow-up appointment at the outpatient rheumatology clinic. And months later, the rheumatology team gave us feedback, kindly feedback, and they told us that the patient gained weight, she had no more fever, and they repeated the labs, and there was a normalization of LFTs of albumin. The only the only alteration that persisted was anemia. They repeated the iron studies, and by that time it was consistent with iron deficiency anemia because the serum iron was low like before, but by that time the ferritin is low too. So they talked with her, and they learned that since 13 years old she was used to have menstrual bleeding. So they started her on IV iron as well as oral supplementation, and the anemia resolved completely. So later they start tapering the prednisone dose, and the patient actually did very well, and it was a happy end.
Oh, wow. Marcela, this is such an amazing case. Thank you so much for bringing it. Uh, I adult onset this cell disease is for me like a very hard diagnosis to make, and I think part of it is because like the road to adult onset goes through all like disseminated infections and malignancies, and I don't know if honestly if I were in you guys' shoe I would have gotten there any faster, to be honest. And I'm just really grateful that she had physicians like you taking care of her who didn't give up, who kept trying it and until like they found a diagnosis, and to hear that she's doing so much better is like why we do medicine. So yeah, this was like such a fantastic case. Nicola, any thoughts from you?
I just want to say thank you, Marcelo, once again. This was such a superb case. The journey was so rich. I think we sort of started off, and I really thought, this is going to be an endemic infection, this is going to be an endemic fungi. Then at some point, I shifted, thinking this is, for sure going to be a lymphoma. And then at the end, it's still, an autoimmune disease, it's Still's disease. Such a really interesting disease which can mimic a lot of things. And you have inspired me to do some reading up on Still's disease because it's such an intriguing disease and can mimic a lot of things. So thank you once again for Marcelo, and yeah, thank you guys for having me. Thank you, Sharmin, for being your co-discussant today.
Oh, Miss Marcella, any other thoughts from you?
Uh, yeah, I would like to share some thoughts about the Still's disease because I never saw a patient before this patient with Still's disease. And I talked with the rheumatology team, and even for them, is not a common disease. So they teach us that this case was a typical presentation of a rare disease to make it harder because we learn at the med school a triad of fever, daily fever, and arthritis or arthralgia, and the Still's rash. And this patient, she doesn't have a rash at the beginning, so it was more difficult. And they told us that the patient with Still's disease, we also learned that they always have a marked increase in ferritin, but it's only true in the 50% of the case. So in another 50% of the case, there's no such elevation in ferritin. So I think it's an important point to think about Still's disease. And in this case, it was a typical also because it's a seronegative disease. And so the majority of the patient DNA is negative, the rheumatoid factor is negative. So in this case, DNA was positive, and it was only noise, it was not signal. So I think it's a very important point to remember. The ferritin is it's only elevated in half of patients, and it's a very uncommon disease. In the majority of the cases, we have to have the help of the rheumatology team. Even them, they sometimes they ask help for the pediatric rheumatologists because they are more used to see juvenile idiopathic arthritis that resembles a lot, as Aldo said, Still's disease. So I learned a lot from this case. So I hope that you learned a lot too, that you enjoyed the case. Thank you very much, guys.
Excellent teaching points, and absolutely a brilliant points about like being an atypical presentation of a rare disease are notoriously difficult to catch. I, and the other aspect that I was like reflecting on is that like sometimes like using your treatment as your diagnostic clue, and I think like it was like the steroids and the tapering of the steroid that really brought out that kind of those typical like the rash, the arthritis, rather than the initial presentation of it. And you just gotta, sometimes you just need time and see what happens. And it's remarkable that, you know, the final right diagnosis was be able to make and she's doing so much better. It's like really, really hard to catch. Kudos to you all. And thank you so much, Marcelo, for teaching us. Nikola, brilliant discussion of a very complex case, my friend. That was awesome. A big shout out to Magnus for doing the scribe and keeping up with all of this information. And Mike, to you, Laura, I'm loving the board so far.
Yeah, thanks everyone. This was a really, really brilliant session and really, really amazing case that gave us this amazing session. And I'm going to be really brief after the amazing teaching that Marcela gave us on AOSD. So we started off with a 22-year-old female that presented with basically systemic inflammatory syndrome with fever, weight loss, and lymphadenopathy. And Nikola shared his approach that can be used in any problem. We just need to ask 3 main questions to orient ourselves into the patient's case. First question would be, who's the patient? And here it was a really young patient, so we need to entertain some genetic diseases as well as ask if the patient is immunocompromised or not. And here is we highlighted really important peril that basically any patients would benefit from HIV testing. And the second question is, what's the tempo of the disease? Here it was more chronic course. And the last question is, the disease localized versus systemic? So basically, are there any systemic localizing clues? And here we had actually a clue to the systemic nature of the disease based on the diffuse nature of lymphadenopathy. And then we learned that the patient presented with systemic inflammatory syndrome. And when we're talking about inflammation, we really need to entertain 3 possibilities. And Nikola again shared the very cool mnemonic AIM to orient us in the 3 main buckets of these diseases. First would be autoimmune, the second would be infectious, and the third one would be malignancy. And to kind of narrow it down, we can filter those 3 conditions through the age of the patient. Here it was young, so it made some malignant, for example, conditions less likely and others more likely, and also the tempo of the disease. For example, chronic tempo made some really common infectious diseases less likely, but made us entertain some atypicals and endemic diseases. Lastly, we talked about also inflammation markers in this patient's CBC and analysis. And here we really anchored on like anemia. And when we see anemia, we don't know really the time course, so we need to exclude acute blood loss first. And then we did an iron studies and learned that the ferritin in this patient was really high. And when we see anemia plus any cytopenias with ferritin in the thousands, we really need to ask ourselves if this the HLH type of picture. And when we entertain this diagnosis, we need to understand what's the trigger of the HLH. And here we have a few buckets, again, like infectious, malignancy, but also rheumatologic diseases. And the most notorious one for causing HLH would be adult Olsen-Still disease. And also really important clues on the unexpected course during the patient's presentation. When we see things that we would not expect to see, we need to consider, for example, 2 concurrent diagnoses rather than 1, when the treatment of one disease triggers the flare of the other disease. But also sometimes to learn more about disease, we just need some time, and we can use time and disease progression as our test, but also we can use the treatment as our test here. And here, initial response to steroids made us concentrate more on the rheumatologic bucket of diseases and final diagnosis, which was AOSD. Yeah, that's it from my side. Thanks, everyone.
Absolutely brilliant teaching points, Laura. Thank you so much for sharing. This was amazing. Thank you all. I really appreciate you. Have a wonderful rest of your day, and we'll see you soon. Bye. Marcelo, I hope to see you back soon. Bye.
Bye. Thank you very much.
Bye, y'all.